Y'all know how I have always, in your freshman semester, how I like to walk and walk and walk and walk, but in here there's that big ass thing smack in the middle, so then I would block and all that kind of stuff. So I am going to move around here, but I'm not going to walk around and stare into your beautiful eyes like I've done in the past, okay? As y'all know, I am very, very, very happy that I was given this, but I'm sad that Mr. Booth is not here anymore. Like y'all know, he has been of a Derm PA for 23 years. He taught me and of other instructors and stuff. But I can promise you, if you have a question and I don't know the answer, then I'm going to call him and put him on speakerphone or something, okay? But yeah. So here we go. It's block 2. We've got all of the bacterial, of the viral, of the, everything else. And so it's going to be going through of the steps. Today is going to be all of the bacterial, right? So this is all of chapter 9 with of Habif, right? So that's of the dermatological Bible. So we're going to go through all of the steps here with conditions, infections, diseases, and that type of stuff. Okay? So skin infections, right? We're going to talk about this over and over again, how it's strep, staph, right? There's some other ones, but as we go through this stuff right here, we are going to see the strep and staph over and over and over. So I know that y'all will remember what is the infectious process of each one of these infections. So we can see how of the staph and the strep are broken down, right? So with staph, we've got impetigo, folliculitis, cellulitis, furuncles, and then the other one, there are some of the ones that are of the same, however, not always. So here's of non-bullets. Oftentimes this is seen with some of the younger kids. They get that honey crusted weeping of the lesions. The non is a smaller one. It is filled with some of the pus, and those things can rupture, especially if it's a child who's always scratching at their face. And there. At the bottom, you can see there how it says that it could be contaminated by staph. And that's exactly what I just talked. The non of the bullous impetigo is specifically for strep, but it can have the staph pulled into it also. Okay, y'all would focus more on knowing which it is. So strep it is. Okay. I talked about the kids. It can be a warm, moist. It can be caused by some of the poor hygiene. So clean your baby. Okay. Yeah. And that's what it looks like. It's all over of his forehead a little bit, but it's more so on of the nares and the oral aspect. So how do we treat it? Okay, we're going to be doing some of the cool, but more of the warm soaks to get the crust off of that. Okay, if it's something small and it could respond to antibiotics, mupirocin is of the topical one that would do if it's not, or if it's localized. If it's widespread, then we would have to get into the antibiotics like Diclox or Keflex. Let's see, there, you could have some of the glomerulonephritis, but y'all, as wonderful PAs, are gonna treat better and you're not gonna even get to that, okay? Don't let it spread. So, wrap it up. There is the impetigo there, right? So you can see the honey crust that is there. These are the pus filled ones that with the scratching or just moving it around, then it's going to come out. And it's the honey crust. That one is a little bit more widespread. It's not showing us what his nose and other things are, so I would probably go with Keflex or something. Even more like right here, that would be all of the topical all over, so we would probably do that. However, remember, if it's a kid and it's kind of small and not widespread, let's give of the topical stuff. So here's the other one now. This one is large, the fluid-filled blisters. That is a little bit more severe than the first one we just talked about, okay? Again, this one is of staph, okay? But this one is not going to be getting all of the strep from the non-one because it's the bigger one. So it's got the staph that could pass it on to the other one. Most common in infants and adolescents. So the impetigo that is bullous, we talked about the first one, that is the kiddos 2 to 5 here. It can be the same, well, it could be of the infants and then of the higher old children or teens. If you're having some of the vesicles, how it's releasing some of the fluid in there, it starts off clear, but then as it's building up and more, then it becomes cloudy. It also has some of the honey color, but it's not as pertinent than of the other one as it will, if we were to take it off, then it's going to have some of the bleed and everything. So it's just having the ooze. So what are we going to do here? It's talking about the hand the washing of the soaks to take all of the crust off. Antibiotics, if it is topical, because it's limited, then it's the same exact one that we talked about earlier. However, if we need to get systemic, then you could see all of those 4 there. Keflex is in there. Topical mupirocin. So this is what they look like. Okay, it's a little bit different than what we saw with all of the honey colored crust. Here, it's already been scratched off, and so you're seeing all of erythematous base. That one, we're going to cut that one off and have to drain it because it's got the pus that's coming out right there. Scratched it and we can see all of the redness up and over there. So that's the first 2, okay? If we're having them happening over and over and over, then we will have to do some of the cultures specifically for staph just to make sure that it's just laying around and around and around and it's not going to go away unless we really do more of the treatment. So we're going to take that off, right? We're going to use a 15 blade, scrape it off, and then use of a CTA to just take all of the pus out of there, and then just cover it up just in case. That topical antibiotic is in these slides a lot. All right, cellulitis. So this is a subcutaneous aspect that is causing them to have some redness, some pain, some swelling that is all there. Okay. The most common, that is the strep that is at work here, but we do have some of the other ones there. Of the locations here is oftentimes of the legs and the feet, because it's more of locations that could have an injury that will amp this up. Okay? Which is what I said of the stasis and lymphadenopathy. Yeah, you see it. That's of the legs and of the feet. Talked about how it's red, swollen, warm, and tender. It does not have a defined border, which we are going to see on erysipelas. Here, it's hard to see like where it's ending as it spreads out. So it doesn't have a borderline, I guess you could say. You could have some of the vesicles and bullae that are also attached or up and underneath of the top skin. Individuals will, if it's like it's already built up, then that could be some of the fever, chills, the white blood cells that are tied up. So what are we going to do with it? If it's an outpatient thing, then it's the same four that we talked about just prior to this. If it's inpatient, then we've got those of the NAFs and the VANC. Pseudomonas with the diabetics. So that's like all of the sins of the CINs. So Genta, la 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 la. Cephalosporins, if there's a flu aspect of it. So here, we can't see the border. Like it's hard to tell that out where it's going at. Okay, this is red, it's tender, and it's causing some of the overall symptoms. This one right here, yes, you can see how it goes from the red skin up until the normal skin, but that's not essentially some of the border. You can see how it's going all the way up and down of that arm. So yeah, it is what it is. Okay, so I talked about these and how they're not having demarcated spots. That is opposed to erysipelas, which does have that. Okay, so you can clearly see where it's at and what we're going to do here. Just like the cellulitis, it does have erythema, edema, and pain. The line that I just passed over, strep, erysipelas, streptococcus pyogenes. Okay? Strep. Red, warm, and painful. Malaise, fever, lymphadenopathy, white blood cells. So it looks like this one could be similar to cellulitis, right? Okay. What will we be treating if it has to be systemic, antibiotics orally, amoxicillin, Keflex, dicloxin, and if it's IV, then it's getting into one of the more heavier things, but amox. And this is what it looks like. So you can actually see that of the border, okay? So you know where that's at. I think I forgot to say that this is oftentimes on the face the ears, and the legs. There again, we can see on its both of his cheeks and his nose too. Right there underneath of the left eye. Y'all know that I'm a 100% San Antonio Spurs, and every time I see this picture, I see Greg Popovich. I love him, but for some reason it just looks like that. But, right? Yeah. All right. So here's now dactylitis. So it's blistering. It's one of those things that is of a superficial infection. Okay. Fingertips. It can also be of the toes. Okay. So it'll have some of the redness. You can see the vesicles, watery, the purulent fluid. Most common, 2 to 16 years old. Treatment, IND. IND. If we were to give some of the anti-strep antibiotics, we'll do that for 10 days. And that's what they look like. Definitely you all can see that an IND would be needed here because we have to relieve all of the pressure that is inside of there and remove all of the infectious fluid that is inside. Now we'll get into folliculitis. We did talk about that of block 1 when he was talking about of pseudofolliculis barbae. So it's the same thing here. It's some of the hair that is now back into the skin, and it's causing that infectious process to happen. Okay. It could also be some irritation of something that is in contact with that area, or physical injury. Okay. Staph. Man, we say staph a lot. So it's the most common. Okay. Nares. It could be where all of the staph is out, and then it can move around. Essentially, when this is happening on of the face and the scalp, you'll have some of the discharge of the oils, the grease, the makeup that could be blocking it all up. Perifollicular pustules with undamaged hair and center. That is when it is superficial, so it's not so much down into the scalp, but it's outside. As I talked about earlier with some of the impetigo, there's some of the culture of the 15 blade to take those things out, put it onto the CTA, and then ship it out so that you can see what it is, because it could be probably staph. All right, so how do we treat it? Okay, whatever that is happening that is causing it to happen, whether it's perfume or lotion or all of that beautiful, good smelling stuff that are being on there, take it away, okay? Clean yourself, okay? Use some good soap, not Bath and Body Works or something, what's that called? Yeah, okay? Antibiotics, 7 to 10 days. Emicin, Clinda, Diclox, and Keflex. Cephalaxine, right? I like to say Keflex because it's easier to say. If it is not being improved by the antibiotics that you're using, then we're going to have to do it for a longer period of time. Usually 7 to 10 days, it works well. You'll have that patient to follow up with you. If they're walking in and it still looks exactly the same, switch the antibiotic up, and we're going to go for a full month or two. And this is some of the looking there. You can see that it's more so on of the neck. Some on the chin, but it's mostly over there. It doesn't always have to be just on your face because the hair is everywhere, so you could have it on your leg. So you can see all of the spots there that would need to be treated. Staph impetigo of beard. So this is specifically to that spot that is on of the beard, and it's inflammation of that entire the follicle. Razor spreads, so it's around. So let's, as we're treating it, do not shave. Let's just let it last. It's the same as the treatment of the staph impetigo, right? So which one was what we were using for impetigo? So it can be topical, and that is, yep. And then if it's oral, there you go. In severe or the antibiotic failure, let's eval for dermatophytes, which we're going to talk about here in a little bit, or remove the hairs, pluck them out. And this is what these ones look like. So this one looks bad, but this one looks even worse. So yeah, beautiful, beautiful, beautiful. All right. So here, furuncle and carbuncle. So it's your uncles, okay? Furs sit in the cars. Furs sit in the cars. And what does that mean? That means that the carbuncle is multiple. It's not just one. Whereas furuncle is a single boil or abscess. Just like the cellulitis, you're having some of the pus that is painful, firm, and fluctuant. Okay, the carbuncle is almost the exact same thing. It's just multi ones. Okay, so your fur is in the car. Both are painful. A deep infection of a hair follicle. It can be located in the friction places of the traumatized, right? So it can be in your groin, in your thigh, in your ass. It can be, just some of those areas like that, which we're going to look at some of the pictures here. Primary management is I&D. So, like I said, if you have your uncles, fur in the car, chop them out. I&D, pull them out, okay? I just made that up right now. Oftentimes, if you have to do this prior to you to enter into your exam room, we'll sometimes put a heating pad on them to just soften it all up. That way then, once we stab, it's going to be able to squeeze all of that out. Systemic antibiotics, not necessarily after I&D, but if it's not getting better, then okay, you could put that out there. But clearly says I&D is first. That's what they look like, okay? So you can see of the center spot, that is where furuncle is at. You can see all of the redness surrounding it, so that's got the infection in there. It is tender, and so it could be one of those things that will just work with that. So there. Here, it's larger, and it's not just pointing at one of a spot that is in the center. I see some lumps and bumps that are in there, so I would call this one a carbuncle. Now this picture here, do we think that we should IND every single one of those? No, I'm probably going to throw some antibiotics in here. Yes, if it's a larger one, I am. I'm going to try. But this is so widespread that it's going to need some of those systemic. But if it's a big one, stab at it. But if you were to do all of those, that's probably going to take you some time, but have fun. All right. I'm showing this picture, but the most important pictures are these ones, and we talked that we were going to, stab them. MRSA, furunculosis, so if it's just going and on and on and on, then it could be some MRSA, so we will have to culture that one out. As you can see here, if we think that it is some MRSA, then we'll be using some of the topical antibiotic in the nares, because that's where all of the MRSA hides out. They like to be in your nose. Once we get back that the culture, then that will push us to which antibiotic we're going to be using. So it's Cedra, it's Clinda, so these ones are there. SSSS, Staphylococcus scalded skin syndrome. Because it's an S after S after S after S, well, let's go ahead and put another S, because this is staph. Blistering disease caused by staph. Again, we're talking about some of the kiddos, so it's primarily with the infants and the young children. Huh? Okay. I'll just hold it like this. Let's see. And it goes off again, and I think it's because of the battery. Y'all know that I talk loud as hell anyways, because it helps. All right, so the toxin, it diffuses from a focus of infection, and then it spreads out, okay? You're going to be seeing some of the pictures like this. And it's similar to Stephen and of the 10, which we talked about last block, because of the fact that it'll have some of Nikolsky signs that show us what this is. Oftentimes it starts with some impetigo, but then it turns into a more severe one just as before, okay? Malaise, fever, irritability, tenderness. Irritability because it's a kid, right? So that's what they're going to do anyways. There's another S right here. It's a sandpaper-like texture, okay? So it's diffuse, tender, redness, and if you to palpate on it and to feel it out, sandpaper-like texture, often extenuated and flexural, and areas. Within 1 to 2 days, the skin is going to wrinkle. Nikolsky is going to be there. So that's if you take your thumb and you push on of the skin, then it's going to slough off. Oftentimes we can do of a biopsy to prove that it is some of the staph. What are we going to treat it? Well, if it's severe, it's going to be the exact same thing as Stephen Johnson and 10. We're going to burn of an ICU-ish to monitor it, treat it, and do all those other things. If it's mild, then it can be some of the antibiotics for 7 to 10 days. So, yeah. Dipox. And that's what it looks like. So you can see Nikolsky's sign is right there. Here of the face, the axilla. So that's SSSSSSSSS. Okay. Pseudomonas, monas. Let's see. So it's oftentimes seen in diabetics. It is in the locations of warm, moist. So it could be your ass, your armpits. What is EAC? Y'all know that. There you go. Auditory canal? Yeah. If you're doing this and you're examining it and you want to use a Woods lamp, you will see some of the green fluorescence. Green. It'll have of a fruity, of a grape-like odor. I wouldn't want to smell it anyways, but for some reason that is one of the signs. There you can see of the picture of fluorescence green once you use the Woods light. Hot tub folliculitis. So here, it's oftentimes, it could be some of the chemicals that are inside of the water. It can be you wearing some stuff that's a little bit irritant, or it's causing some things out that develops into the symptoms here, right? So it's itchy, it's round, it's urticarial, plaques with central, papule, and pustules. So y'all know all of the papules and the pustules because you did it all in block 1, knowing what they are, what they look like, and how we fix them. They can also have a low-grade fever. It's not going to push us to sepsis, but we can't rule it out. We could do some of the antihistamines as needed. If it's localized, so it's on 1 foot or it's somewhere, vinegar soaks acetic acid. So if they were in the hot tub, give them some acid or something, okay? Because, yeah. If it is more involved, if it's more severe, if it's widespread, then yes, we're going to use some of the Cipro twice a day for 5 days. That is more of a widespread, so I would use of the Cipro. That one, not as much. That one looks like it's in 1 spot, so that would be of us doing of the acid. Acid. Pseudomonas cellulitis. It's oftentimes seen in some of the sick people or that have a disease process like diabetes. We would see these things happen on the toes, the groin, if they're constantly inside of a bed and they have those sores. Stasis, right? So that's of the legs with ulcers, burns, grafted areas under the foreskin if they're not circumcised, and after injury. We will want to have them occlude of the cellulitis, and we want to do some broad spectrum antibiotics. Soldier in swampy environment. I didn't write that, he wrote it, so I didn't put airman, okay? So we're good. And again, just like of external auditory canal that we just talked about, you will also have this one at the ear. How do we treat it? We have to, if they have of the diabetes, then of course, we're still going to be checking their labs, their sugar. We're going to watch them for sepsis, but it's just written it up there, reminder. What we will do is if it is not widespread, if it's not severe, then again, acid, acetic acid. So if these are low, then acetic acid it is, because we're about to talk about it a few times. If it's systemic antibiotics, because it's severe, then again, it's the exact same thing of Cipro twice a day for 5 to 10 days. And that is what they look like. That is right there of the groin inguinal area. There are the other places. Foot looks nasty. Of the ear, so it's all swollen. We can see of the redness. Is it going to hurt? Yeah. Web infection here. This is oftentimes in between the smaller toes, right? So it's of the 4th and 5th. Thick and macerated, so it is cut up. Woods light, greenish here as well. It could also have a mixed infection because we could have of the yeast there also. I don't think that this is going to smell like fruit, but I'm still not going to smell this one either. Okay? Here's acetic acid again, damn. So oftentimes we have to keep it clean, dry. We have to lock it up a little bit there just to let it heal up. Where can we have it? You can see on that chart right there of the underarms, sweaty hands, sweaty feet. If we do have to prescribe an antibiotic, again, ciprofloxacin, 750, 500, twice a day, 5 to 10 days. Tricho. So this is gram positive, wet areas, axilla, groin, web spaces of the toes. You can tell there that it's Bacterium, whitish or colored hair. So this is just of the hair. Okay, it stinks. It is horrendous. It smells so bad. But you can see all of the white stuff that is on of the armpit hair, of the groin hair, and no bueno. Oftentimes it's because of the heavy sweating. I deployed with your wonderful EOD units, and it was a little sweaty out there, so I did treat some of this. And it's easy because it's just some of the topical erythro. That is the natifine that is also there. If it is, having some of the fungal aspect added to infection. Control hyperhidrosis. Use some good deodorant. That is what it looks like. So you can see all of the white that is attached to the hair. That one shows us a little even more. Okay. I'm almost getting y'all done. Erythrasma. Again, this is some of the Corynebacterium that is there. We can see that it's got some of the similar stuff as of the trick with warm of the humid, poor hygiene, hyperhidrosis, obesity, diabetes, advanced age, and immunosuppressant. Immunosuppressant, Mr. Booth talked about that last block. Yeah. Fourth, interdigital space. It can also be in all of the other of the moist places. This one, though, however, is not like the tinium, because this one is not skipping of the scrotum of the labia, right? So it'll go all the way up into the please don't hurt me there spots. Macular brown red, scaly, non-inflammatory, itches and burns. And if you do of the woods lamp, this one is coral red fluorescence. So it's not like the other ones, which we were seeing some of the green. Like everything that we have been talking about over and over, keep area clean and dry. Topical, we can use erythro or Clinda twice a day for 2 weeks. If it's severe or it's not healing up with the topical, then we're going to go with the oral of clarithromycin and erythromycin. And here shows how it's all of the growing area, but it's also it's moving into the labia, so it's not just keeping those sites uninfected. We talked about it being on the fourth spot. It can also show it up over there, spreads it apart. You can absolutely see how that woods lamp is, and it's coral red. Once we shine it on there, it's also showing how it's not only on the legs, it's also up onto the testicles there. The other one is in the armpit. So here, this is more of the individual, or of the stuff that is on the bottom of the foot, okay? So it's almost like we saw some of this with psoriasis, how it could be on the hands, it can be on the bottom of the feet, but this one is not cirrhosis, as this is a infectious process of a bacterial infectious process. So it's in the weight-bearing areas of feet, which that's pretty much everything down there, but it can be more on of the heel and then also of the toes and everything up there. Hyperhidrosis, most frequently observed. Malodor and slimness of skin are distinctive features. It can be the tropics, so if you're on vacation and you were walking in the sand and the water and then, started to have this afterwards, it's an infectious process, so let's go ahead and treat it. Occlusive footwear, what's that? All of the boots that y'all have on right now. Yeah, anyways. Treatment. Again, clean, dry, socks, footwear. The treatment of choice is of the topical erythromycin ointment. Or you can use the other two, but erythromycin. You can also use some of the Drysol, to help that out. If of the topical antibiotic isn't working, then we can do oral of the exact same medication, erythro. This is what the pictures look like. So you can see how it is predominantly in of the heels and of the forefoot and toes. Specifically right here, you can see that it is on the toes. So it just likes like some pits. There you go again. All right. We talked about all of these things from the beginning to the end of the bacterial infectious. Do we have any questions? Good, because I don't know if I was going to tell you. All right. We will be back tomorrow at 10, and we'll be going all of the viral stuff, okay? Y'all can see how all of the slideshows are like 70 slides, 80 slides, but half of that is pictures, okay? So it's not like I'm just always going to be up here for an hour after hour after hour, because y'all know I don't want to.